Thank you very much for the nice introduction, and I'm also really happy to be here and that I was invited. And I hope I can introduce you today something about urticaria. Especially, I will make a big focus on the pathogenesis. I will make a short introduction about the clinic and the typical treatment at the moment. But the focus is to what we really want to do is to better understand the disease so we can develop better treatments that maybe are more individualized. So I have some potential conflict of interest, but I'm really trying not to favor any company here with the talk. The urticaria, there is a current guideline, an international and also a German-speaking guideline. So if you even want to dive more into the topic of urticaria, these are the ones where you can have a look at it. There will be an international guideline update or meeting for an update will be this year, so probably next year there might be a new international guideline coming. What is urticaria? Urticaria is a disease that is defined by the occurrence of wheals and or angioedema. And if a patient has this, the chances are very high that the patient has a urticaria. They have, the problem is not so much for some patients how they look like. The problem is also that this rash comes with a very severe itch that inhibits the patients from sleeping or even doing normal things on their day. And the angioedema, the severe swellings, they can even burn or give really a pain to the patient. And it doesn't really look nice, and it's really hampering their function. And if it's around the lips, for example, or the tongue, then it can also evoke fear in the patients. So how are we grouping the different forms of urticaria? There are two big groups. One is the spontaneous forms of urticaria, and the other ones are the ones that are inducible, so where some physical triggers typically can evoke the symptoms. And in spontaneous urticaria, why there is no really a trigger for the patients visible, it just comes and goes. And if this lasts for more than 6 weeks, then we are saying this patient has a chronic urticaria. How does this look like? In spontaneous urticaria, it can be anywhere, all the time, anytime. In inducible urticaria, typically is there where the physical trigger is on the skin. This is an example of a cold urticaria patient, and you can see where their cold contact is happening on the skin in these round circles. Exactly there, the patient develops the wheal. And it's the same for another very frequent form of inducible urticaria, Urticaria factitia, it was called before. Now it's more symptomatic dermographism. When the skin is scratched, the patients develop a wheal exactly there where the scratching of the skin happened. So how common is this? About 20% of all of us will have at least once in their life a urticaria, most often acute urticaria, so not lasting for a long time, and very often already in childhood. But if I would ask, I guess several of you already had at least one once in their life such an experience. Who is more prone to develop than a chronic form, which lasts more than 6 weeks? This double as often as men are females affected, and there are estimations because it is so frequent and chronicity can happen, so that about 1% of the population is thought to have to be affected with a chronic urticaria. If we now look on these different forms of urticaria, what can we see? So most commonly here in blue are patients with chronic spontaneous urticaria. I already said symptomatic dermographism, so where scratching induces the wheals is also very common. And cholinergic, where sweating actually induces the whealing, or cold urticaria are also other more frequent form of inducible urticaria. But it's not so that the patient only have one form. Actually, we can see that about 1/3 of the patients have actually mixed forms. So they can have several triggers, and most common, if we look here, is a combination of chronic spontaneous urticaria combined with the symptomatic dermographism. But all other different forms of combined urticaria is possible in the patients. So this means that they can have spontaneous and triggered urticaria at the same time. So what about diagnostic? What do we think for a long time? Where did this stupid disease come from? So let's say 20 years ago, nobody really knew. It was thought that there are a lot of triggers of what really causes urticaria, starting from infections, drugs, emotional stress, you see all sort of things. And also recommendations, they were really all over the place, starting from just relax, trying to not to stress out, stop smoking, don't drink alcohol, do not wash too much with soap, and so on. So a lot of different concepts, not really helpful for the patients. Also, when I was started in Berlin, this is already now 18, 19 years ago, we put the patients on the ward for 1 week, and we were really doing with them everything you can think to look for some cause. So they were on the ward for 1 week, x-rays, sonographies, blood work, extensive, yeah. So we really tried to look for any kind of trigger, but typically you wouldn't find one. So after 10 years doing that, we finally made an analysis and saw this does not really help anyone. It's just making a lot of effort, but it's not really helping the patient in any form. And the new urticaria guideline also takes this into account when we see what kind of diagnostics we should do with patients with urticaria. It really is now very limited. You should rule out that there's something really severe happening with the patient, typically done with differential blood work and CRP levels. And we will come to that, why that is interesting. We should measure total IgE and IgG anti-TPO. And it's also recommended to look out for these inducible forms of urticaria, because then you can make specific recommendations for the patients. And that's already it. So the diagnostics is really limited. That is, let's say, recommended by the guideline at the moment. But we can immediately start with treatment with these patients. So the treatment usually starts with taking antihistamines. And these we have along for the patients for, I don't know, more than 50, 70 years now. So they are very well experienced drug to work with, but very often it is not enough, especially with the recommended or licensed dose of 1 tablet a day. And there are at least case series and small studies that showing that if you increase the dose up to a 4-fold daily dose, that this increases the treatment efficacy for the patients. But be aware, if you do this as a physician, it's off-label. You have to tell the patient. What are you doing, or what are we doing if this does not help, if it still does not help? So omalizumab is licensed for the treatment of chronic spontaneous urticaria in a specific dose of 300 milligram every 4 weeks. But if this does not help, the guideline can also recommend that you can updose. But this, again, would be off-label for chronic spontaneous urticaria. And you have to keep in mind that there can be some occasions, like pregnancy, children below 12 years, and so on, which would also be off-label, although there are data supporting that you can do it. But that would be very specific cases. If you really look onto the text, you also would see that chronic inducible forms of urticaria, they are not specifically in the label, so that would be also off-label. So this is a very good working drug in many patients, but still there are some patients where this is not enough, and the current guideline suggests to go on with a therapy with cyclosporin, a drug that has some limitations. You need to have regular blood checks with the patients. You have to check the blood pressure and so on. There can be some limitations of using it. And again, if you're looking very close, it's again off-label. It's not really license-specific for the treatment of chronic urticaria. So you see the treatment algorithm is pretty short and simple, with not so many drugs available as a licensed drug. But even more the trouble is coming if you have a patient and you maybe even tried all, or you cannot apply all the drugs. It's only 3 here, more or less. What are you doing then? So then the guideline says, okay, we also don't know. These are the drugs that had been tried before with the treatment for urticaria patients. You just might pick one, kind of. Yeah. So you see, this is all sorts of drugs that had ever been studied, immunosuppressant drugs, but also things like psychotherapy and so on. So yes, you can try everything. So a little bit the problem comes with urticaria that the pathophysiology was never really well understood. So the question remains, what would be the best approach to go with these patients? One specific feature about urticaria is that these patients have some interesting features. So very often patients have a little bit elevated total IgE, but if you look, you cannot really find a typical allergic trigger, or even if you find a pollen allergy, that clearly does not have to do anything with their recurrent urticaria. We know that an anti-IgE therapy works because it's a recommended drug, but these patients very often also have other features. They can have some features of IgG autoimmunity, like IgG anti-TPO or positive anti-nuclear antibodies. They can have a positive ASST. We come to that later, an autologous serum skin test, so they are reacting to their own serum in a way. And they have another interesting feature, like they can have very low basophils or eosinophils in the peripheral blood, and this is especially associated with a high disease activity. So if you look at that, these patients, they have some features of allergy, kind of, but they also have some features of autoimmunity. So it's not so really clear what's really happening there in these patients. So something that is very clear from very early is that a central role in this disease has the mast cell. And if this degranulates, it releases a lot of histamine, and that's probably the main culprit of the symptoms that the patients have, the itch, the whealing, this vasodilatation that we see in these patients. But for a long time, it was not clear how these mast cells are actually triggered. There had been some very old concepts. You see, they are now 100 years old, where there were the first studies or the first ideas that you could maybe be even some sort of allergic or reactive to your own skin. And this was really looked at. Furthermore, we know that chronic spontaneous urticaria is very often associated with some sorts of thyroid diseases, for example, and also other autoimmune diseases. And especially a lot of urticaria patients, they can have high levels of IgG anti-TPO. And this led us to the idea to look for if this patient maybe also could have IgE autoantibodies to themselves. And this was a study where we were looking if patients with chronic spontaneous urticaria have indeed higher levels of IgE anti-thyroid peroxidase compared to healthy controls. And later on, it was also screened for other autoantigens, for example here, IgE anti-IL-24, but nowadays even more and more autoantigens are developed or exhibited in chronic spontaneous urticaria. So one of the pathophysiological mechanisms that now is thought to be very important in chronic spontaneous urticaria is that a lot of patients have autoimmunity type 1 or autoallergy, where the patients have IgE against self, and if then they encounter autoantigen, this leads to the degranulation of mast cell. But this is not detectable in all patients, and there must be something else happening in the patients. And when we look back about 30 years ago, a group in Vienna has developed that patients with urticaria can have IgG autoantibodies that are directed against the alpha chain of the high affinity IgE receptor or to IgE themselves. Unfortunately, although this is 30 years ago, there is still no commercially available ELISA or any sort of method how you could really detect these antibodies. Some groups have tried that. I have also tried that. It kind of works, but not so reproducibly. That's a little bit a problem with these measurements. But it is established that patients with chronic spontaneous urticaria can also have IgG autoimmunity, and this was termed autoimmunity type 2B because it's not complement fixating, to have IgG against the IgE or against the receptor that leads to the degranulation of mast cells. Very often these patients also have other features of IgG autoimmunity, as I said, like IgG anti-TPO, for example. And since they are more like sort of IgG-prone immune system, very often these patients have low total IgE. What is then happening if we treat these patients with an anti-IgE drug like omalizumab, what we do, or as a recommended therapy in these patients, we take away the IgE. And this is happening pretty fast. And once we remove the IgE, it cannot be loaded anymore onto the cell. And so this mechanism is blocked. But in autoimmunity, if the IgG is directed not against the IgE, but against the high affinity Fc epsilon receptor, the IgE is not playing a direct role immediately here. So this mechanism can still happen. And if you have that type of pathophysiological principle of your urticaria, you still get mast cell degranulation. It will take a long time when the IgE is gone, where eventually this will lead to a downregulation of the high affinity Fc epsilon receptor, and this then will inhibit this autoimmune phenomenon in your body, and you will eventually get better with the symptoms. That this is not just a theoretical concept had been shown in clinical trials where patients were treated with omalizumab. And patients were grouped into two groups. Patients that had features of type 2 autoimmunity, they responded much slower compared to patients who did not have these features, so who were probably type 1. So you can see this really has a direct impact on how they respond to the treatment. Furthermore, as I said, sometimes it happens, patients do not respond at all to the treatment of omalizumab. And when they were looking what is the difference between responders and non-responders, you could also see that they have more features of type 2 patients like low IgE, elevated IgG, anti-TPO. On the other hand, these patients with a more type 2 features, as I said, low total IgE, higher levels of anti-TPO antibodies, they responded actually better to a therapy with cyclosporin A. So if you would know what type of patients you have, you could predict a bit better what therapy he probably will respond to. Oh, now it's frozen. Oh. So the problem that we have with this detection of type 2B is that type 2B immunity, as I said, the ELISA is difficult, so there is no commercially available ELISA, but there are other surrogate markers that can be used. For example, a positive ASST. This is a test where you inject the serum of the patient into their own skin, and the patients will develop a wheal. This is a kind of complicated test. It takes a long time. First, you need to generate serum. Then you have to make sure that you don't mix up the serum and not injecting the wrong serum into the wrong patient. And then he has to sit there for another half an hour and read. So, it's quite of a laborious task to do in routine practice, so not so well received by physicians, I have to say. But the good thing is that there are some other markers for type 2B immunity. For example, basophil histamine release assay or basophil activation tests, where basophils of healthies are incubated with patient serum, and this activation gives you a hint that the patient has type 2 immunity. So as a summary of that, typically patients with chronic spontaneous urticaria have more preferentially type 1 autoimmunity with typically IgE against self. One example here with the TPO. Typically, these patients have normal or high levels of IgE and they respond very good and very fast to an anti-IgE therapy, whereas there are the patients with type 2B autoimmunity, which have typically low IgE but positive IgG anti-TPO. Which have a delayed or bad or even no response to anti-IgE, but very often an even better response to cyclosporin A. That maybe the world is not just so black and white, and type 1 and type 2B comes from this more recent study where we looked how many patients maybe even have features of both. So like autoallergic CSU and autoimmune CSU, and we see patients can even have features of both. So probably it's not that you either have one or the other, maybe it's also like a little bit of an overlap that is possible in these patients. And that the mast cell is not a cell that's living on its own in its own little world, but it's really connected with a lot of other immune cells, and that probably this is all much more complex. It's just an idea here on this slide. And better understanding of the pathophysiology really has also led now that more drugs are studied in this disease. This already leads me to my summary slide, where I hope I could show you that chronic urticaria is a very frequent and common disease. There are some clinical subtypes, typically the spontaneous and the physically inducible forms of urticaria. The current recommended routine diagnostic is rather minimal, I have to say, maybe too minimal, maybe something to discuss. And the current therapy algorithm that we have also, so antihistamines, anti-IgE therapy, or cyclosporin A. The pathophysiology is not 100%, I would say, completely understood, but I think it's pretty established that we have these kind of two major subtypes, the type 1 autoallergic form and the type 2B more autoimmune type. And as I showed you already a little bit, it depends what type you have if you respond better to the drugs that we already have, the anti-IgE or cyclosporin drugs. And I don't want to talk too much because there will be something about the new drugs, but especially also for the new drugs, we see that it really depends how you respond to the drugs, depending on what pathophysiological subtype that is. And the more drugs we have, it might get even more interesting that we know beforehand what type the patient had, so we can be a more individualized therapy regimen for this patient. And with that, I thank you for your attention, and I'm happy if you have any questions.
Thank you, Sabine. As good as expected. So, do you have questions to the expert who will leave the country tomorrow? So that's your one chance. Thanks.
So thank you very much for the very interesting talk. So do you know of any patients where people have tried to treat with rituximab in these autoimmune type 2 patients?
Actually, I would not be aware of really published data on that. it would kind of make sense but I'm not aware that. I wouldn't say it's not there, but I'm not aware of
I'm just astonished because often rituximab is also given due to other diseases, and maybe some patients may have had another disease that would allow for adding rituximab. And
I think it's on the list of these drugs.
Okay.
It's there, but I do not recall really the results or what was the outcome of it, or I'm not aware of the publication, but I think it's on the list somewhere. Yeah. So there must be some things, but I'm not aware. Unfortunately, I'm not aware of the. But
Right.
Probably something we could look up. Yeah.
There are some people or some patients who have just dermographism.
Yeah.
But do they have any of these signs with
So there are patients who only have a dermographism. So if they scratch, they develop something like a wheal, but without the red and without the itching. And very often the patients are not limited by that. It's just an appearance thing, and it's also transient. So very often it also lasts only for a few years and then it goes away again. It's also, as far as I know, not at all understood what is triggering that. Somehow it seems it can't be histamine, well, because why is it not itchy or red? So the typical other signs that you see with histamine.
And the overlap between dermographism and CSU?
Yeah, they have symptomatic dermographism. So
Symptomatic
they typically have the itch and the red with the wheal.
And is there a difference in the analysis with regard to autoantibodies?
With regard to autoantibodies, I know that there was a study that was looking for type 1, so to look if patients have more type IgE autoantigens. If you also have a physical type of urticaria, there was a slight overhang to maybe yes, but not really, I would say.
I'd have a question as to the frequency of positive TPO antibodies. In my experience, I can say usually in chronic urticaria you do not find any etiology. Most often maybe an autoimmune thyroid disease or maybe positive ANA, maybe some patients with positive parasitology. But how often do you find positive anti-TPO as they're needed for the definition and for the diagnosis of those two types of autoimmunity?
Now, I think, so especially if you have a patient who is a woman, then your chance, there's like a trial out there, your chance that these patients will have a thyroid pathology is really high, like, I don't know, every fifth or so. And even if you have a man, also their rate of a thyroid pathology is much higher compared to the normal population, not as high as in female patients with chronic urticaria. And I measure it always with my patients, and I frequently find IgG anti-TPO antibodies, very often without a thyroid pathology. So it means they are still euthyroid, how is it called in English? Yeah. So they don't need a therapy for the thyroid, but it still tells me there's something going on. And you know, this is very often also associated with other forms of autoimmunity. They can have with vitiligo and other types. So it tells me it's a patient who's more likely to be in the type 2 form. And these patients have more severe disease, longer lasting disease. They do not respond so well to the therapy. So this is why you kind of can, in the beginning, already make some expectation management, maybe also with the patients.
Another question is, have you ever seen patients with chronic urticaria, let's say, but without hives?
With only angioedema, yes.
For example.
Yes, definitely. So also the data suggests something like 10% of patients with a chronic urticaria only have angioedema. Yes, it exists. And sometimes you have patients who only had once hives and angioedema and then only angioedema next or so, this is possible. But they also respond typically kind of nice to the therapy algorithm.
I mean, another example could be someone who has chronic pruritus that responds to antihistamines, but never had seen any signs of angioedema or hives.
So I think chronic pruritus is another whole pot that you're opening, right? I think this is, again, you have to look for a lot of underlying possibilities, what's happening there. And in my experience, antihistamines rarely help sufficiently.
I was talking about a patient that say he took antihistamines for 5 years, never had any sign of urticaria, but when he forgets to take in the antihistamine, he has the itch, chronic itch. And don't tell me that itch alone. I would say there is a form of urticaria without hives.
So something that I can definitely say is, especially patients with symptomatic dermographism, they often do not tell you that they have these scratchy wheals. They come to you and tell me, I have such a bad itch. They are not really complaining because they think this whealing they get is secondary just because they scratch. So yes, it's possible that the patients have as a primary symptom itch. In your special case, I don't know if they're, very often, let's say, if patients stop taking antihistamines, the first sign is that they get itch, and eventually if they stop longer, then also the whealing comes. That would be my experience. But really to have something where you never have anything to see on the skin, and it only itches, hard to say.